Hello, everyone. Welcome to our special free Ask Me Anything webinar. And I guess it should be an asterisk on that, right? Ask Me Anything orthodontic related webinar with our editor, Dr. Neal Kravitz. Before we get going, I have a few big housekeeping items to discuss. The first is what you see on your screen, which I know not everyone here is a subscriber. This webinar is free. Usually the webinars are free only for subscribers. It's usually a subscriber benefit. As you can see on the screen, you also get free access to our digital shorts, the whole archive, and of course everyone knows about JCO. So if you are not a subscriber, if you are a lapsed subscriber, please do think about renewing or starting a subscription. The link is on the screen. There's a QR code on the screen. It would mean a lot to all of us if you would sign up. And I just want to point out here that what you're getting, these are all of our recent webinars. You can see this on our website. So subscribers get all these for free. Non-subscribers generally would have to pay for them. The digital shorts, we just put up a new one. You can see down here, this one is subscriber only. And then the last thing I need to talk about is our practice study. This does not relate to subscriptions, but we have just opened the 2023 practice study. For those of you who don't know, this is basically the gold standard for data on practice management in the United States. We've been running it for over 40 years now, and it's getting harder and harder, quite frankly, to get people to fill it out. So anyone who is in attendance who is in the private practice orthodontics in the United States, I am sending out to the chat right now, the link to the practice study. You can also see the link on our website all the way down here at the bottom over here. And yes, we are going to have a drawing for people who complete the study. One person is going to win a free lifetime subscription to JCO, lifetime. So please do the study. And actually, Neal, it takes more than 20 minutes. I don't want to lie to people, unless you really have your stuff together. It's not easy, but it's actually really beneficial stuff for you to know. It's not just for the profession's benefit, although it is. It also should benefit your practice. So the way we're going to do this tonight is questions. Type them into the questions pane. You see them. You should have you have a little strip on the side of your screen. In there, there's a little thing that says questions. Type those in, and Dr. Maru will be moderating, basically. So I will turn things over to him.
Awesome. Well, first off, thank you, Phil and Neal, Dr. Kravitz. I don't need to say this again, but this is my favorite webinar of the year. We did it last year, and getting to hear from you, your expertise, I absolutely love it. I think we're in for a treat tonight. So those of you in attendance, as Phil said, if you type in questions, I'm going to be moderating. I'm going to be throwing out anything goes tonight. Residents especially, I know that we already have well over 100 people on here right now. Residents especially, if you have questions, throw it out there. Dr. Kravitz is one of my heroes in orthodontics, and we're, I'm excited to learn a lot. So I'm going to throw out the first question to you, and let's get rolling. So here we go. First question. Dr. Kravitz, your finishing is so top notch, along with everything else. What are your standard finishing wires, mechanics, techniques?
Yeah, thanks. Great question. I'm excited, Dita. We just solidified the topic for the winter conference next year in 2024 in Texas, and the topic will be on finishing and detailing. And the lineup of speakers is gonna be amazing. So, finishing, I think, is the subject that we all struggle with. It's the most important phase. I always like to say to the staff, you have to walk through the finish line, right? We're working so hard to get there efficiently, and then when we're there, we have to slow down. So first and foremost, when I get to about 20 months of treatment, and a lot of people they say, well, I average 18 months of treatment. I don't think that's accurate. I think most cases in fixed appliances, unless you're using customized appliances, I think it's about 24 months. So when I get to about 20 months, I go to a 4-week protocol. So I do want to see them more frequently, and I do minor adjustments. I'm using an 022 slot bracket. And then I actually step down. Believe it or not, I actually like to go to a lighter wire and sometimes even finish in a round wire, even an 18 steel or a 1725 steel. So my feeling about torque is that it's hard to get, but you don't really lose it once you get it. So you have to, what's the old line? Torque takes time. So once you get your torque established, or if you haven't lost torque by controlling your mechanics, at the end of treatment, I usually step down even to an 18 round. I use that 18 round in place of TMA wires, which I just don't use in my practice, which are great though. I highly recommend. So I actually like to finish in lighter wires, even though I do build to 1925 and 2125 regularly.
Awesome.
And then just kind of add to the finishing. One of the little tricks that I like to do is actually, if I can, debond one arch at a time. So if I'm done with the lower arch, I will take off the lower braces, put a lower fixed retainer, and get some natural settling. And a lot of times, just getting off the braces gets you some free finishing. People comment on the finishes, but I will tell you the last little trick that I do is those final records are taken 3 months after debanding. So a lot of people will say, your teeth look so clean. Well, I appreciate that, but that's also 3 months afterwards. So my favorite thing that I tell people with finishing and detailing is when your case is done, it doesn't look as good as it's going to look until the next appointment's when it looks the best. So I actually tell my patients, go to your dentist after the final records appointment in 3 months, because I want one more time to look at the teeth, sweep it for making sure there's no overhangs, there's no flash. So I step down wires and I take those final records one appointment later.
I love that. And I actually do something similar. Thank you for that. Next question for you.
I love these attendees numbers. So many great people. The number keeps going up. I'm really honored the number of people that are attending today. That's awesome. Thank you guys so much for your support.
Same. Like I said, this is one of my favorites, if not the favorite. Okay, next question. So I would like to ask Dr. Kravitz one question related to the maxillary expansion protocol in the early treatment of class 3 malocclusion. What is your opinion between the conventional protocol of RPE, meaning only expansion, and the alt-RAMEC, so alternate rapid maxillary expansion and then constriction? What is your choice, and can you explain the reason? Thank you.
Sure. So for the residents who are here, the alt-RAMEC technique really started at the JCO with Eric Liu. Eric Liu is a name you should all know. He is one of the great orthodontists of the world, great teachers of the world, and he's had many great articles published in the JCO. And this was a protocol where he established where he would expand, constrict, typically do that in weekly intervals over about 5 weeks. And the theory was that it would loosen the maxillary suture, kind of like an in-the-mouth Le Fort that you were creating. It's debatable how effective this is. And we actually have a reemergence of the alt-RAMEC technique now with skeletally supported expanders. So they're calling it like a SCAR technique, S-K-A-R, skeletally supported alt-RAMEC. You'll see publications in the JCO on this. But to answer your question, for little kids, I keep things very simple, and I'm just pretty traditional. And I'm not even going to use skeletal expanders on young children or adolescents, even though I know some may disagree. I keep it pretty simple, pretty conservative, and I'm just going to use a traditional protraction Hyrax. I will like to add one thing. So a lot of class 3 patients that we are treating early are because they're maxillary deficient, right? If we have early signs of prognosticism, we're not going to be treating early. We're just going to let that mandible grow and prepare them for surgery. We can't stop the lower jaw, but we think we have a mild, maybe temporary benefit on the maxillary arch. So there is some benefit if they are maxillary deficient versus if they have mandibular excess. But a lot of patients who are maxillary deficient have the arch length constriction and have impacted labially displaced canines. Okay, that's a lot of information right there. So you have a narrow arch, a deficient arch, a hypoplastic arch, and now you have high labial canines that are right on top of the lateral incisors. So if you start running a heavy protraction force off your expander and you don't advance the incisors, you will take your buccal segment, premolar to molar, which is really deciduous molars, and permanent molar and shove them into the canine space. And a lot of times you will worsen the impaction of the maxillary canine unless you're also advancing the anterior teeth. And a lot of times you shove the canine right into the root of the lateral incisor, and now it becomes an upper extraction case and really a Lefort surgery preparation. A lot of information there. So if you are class 3 with maxillary deficiency, watch your upper canines. And in summary, what I do is I expand. I overexpand 35 turns, maybe 40 turns. I'm not worried about a buccal crossbite. I'll wait for those labially displaced canines to go down into that funnel past the danger zone, which I call the upper third of those lateral incisors, where I know resorption cannot happen, and then I protract. So I actually don't protract until I know my canines are safe. This is an article that I've been dying to write about because I have all the illustrations, but it's a theory that I have.
I want to read this one.
Well, it's a theory because I've protracted because I don't like to place braces early. I protracted, and all I think I did was advance the buccal dentition into the canine space, and I think I worsened the impaction. And so that's my theory, something to keep an eye out for those class 3 cases.
That's amazing. I love that. Can I ask it's a personal question. In those situations,
you got to call me Neal. I'm not going to let you call me Dr. Kravitz for the next 45 minutes.
Neal it is. You talk about expanding into buccal crossbite because you need so much room to bring those canines down and not risk lateral resorption, things like that. Do you ever use a Schwartz appliance on the lower to expand the lower slowly? I mean, what is your thoughts on that?
Yeah. So I've written a lot of articles in the JCO on the E-arch or the Arnold appliance. So I'm totally for that, right? These are not really expanding appliances. They're like dental tipping appliances, upright appliances. I think everybody knows that we're using expansion loosely or really inaccurately, but we all know that we're not expanding. We're really temporarily gaining room for these teeth to fit or really upright. I have no problem with that. I will tell you though, in my years, I've kind of moved away from lower standing appliances. I think they're fine, but I like them if I have a Brody bite, and I want what I will do is I want the tipping of the lower, and I actually will flip the key, and I want constriction of the upper. It's a little technique that I like to do.
Love it.
But so I definitely do it. I think the advantage of a lower E-arch is if you keep the tubes on the lower 6 bands, it prevents a buccal crossbite because the patient can't slip down the buccal cusp. So if you do a lower E-arch, don't tell the lab to remove your buccal tubes because those buccal tubes prop open the bite and it lets you jump a buccal crossbite. So, but I have moved away from him. I have moved away.
No, thank you for answering that. I appreciate it. Next question. We've got a bunch coming in, so I want to make sure that everybody gets there.
I love the attendees. Keep coming up. I'm so grateful all these people coming in.
Next one. Simple question. What is your retention protocol?
Prayer, right?
Oh my God.
Here's my thing about retention. I lecture a lot on retention. My big thing for those, and I hope we're known for this, is we're very not financially driven, and retention is a practice management decision. So, we're famous in our community. We never charge for the retention phase. So if somebody loses retainers or their teeth relapse, or whatever, we just fix it. We don't charge. Maybe if the parent overrules me and doesn't do a bonded retainer, the next time around they're getting a bonded retainer or something like that. But I want my cases to look good, and honestly, I get better every year, and I wish I was doing things better earlier on. So if I get an opportunity to redo my work, I welcome that, and I would never charge someone. So I don't charge for the proverbial phase 3. And this lifetime guarantee has really made us quite well known in our area, and it gives me the opportunity to correct mistakes because we get so much better every year because we're seeing so many thousands of patients every year. So my
Wonderful.
traditional retention protocol is an upper 2-to-2 bonded retainer, a lower 3-to-3 bonded retainer with overlay retainers. The best retainer is a removable retainer. Bonded retainers do not hold the occlusion. As I like to say, permanent retainers are temporary solutions. So the best retainer is going to be Essex or Hawley retainers. I still like overlay, circumferential Hawleys. For the bonded retainer, I want to go over that specifically. I have changed my protocol a little bit. I used to use bonded braid in the upper arch, but I'm moving toward Retanium. I like all things Reliance. One, Paul Gangi is just a great person, and I love supporting him. He's
use
also a great
Retanium as
supporter
well.
of the JCO. So I would welcome anyone to please consider using Reliance. They're great to the JCO, but they're just a great orthodontist-supported product company. I like Retanium in the upper arch. Bonded braid is very good. It just breaks. It just frays a little bit.
Yeah.
I don't like OrthoFlex in the upper arch, which I used to use, because with a thick tissue phenotype, even if the retainer stays bonded, diastemas can reopen. Very frustrating. Retanium is a little bit harder to use, but boy, that thing is in there and it works great. So I use upper Retanium. I like FlexTech in the lower arch. So I'm using stainless steel OrthoFlexTech in the lower arch, lower 3-to-3. My composite is either Transbond LR, but I actually sometimes like to use Tetric EvaFlow, which is a very high quality flowable. And then I like an overlay retainer. I love an upper circumferential, but I have no problem using Zendura or Essex, whatever we're using. The lower, I don't like circumferentials. I think they're just too flimsy. I just like a traditional Hawley or just an Essex retainer. So I like belts and suspenders.
Love it.
But truth be told, the best retainer is a removable retainer.
100%. Awesome. Thank you for that. And for everybody who's attending right now, last year, Neal gave a webinar on retention. It would be worth logging in and checking that one out. It's one of my favorite webinars you've done. So just to promote that a little bit. All right, on to the next question. Thank you, Neal. So this one's a little bit longer. I'm going to read it to you. Hi, Dr. Kravitz. Love all your work and how you support the field with the JCO. I'm a resident and struggling with patients who have poor oral hygiene and broken brackets. I do my best to communicate with them and emphasize that we are a team, but I'm not seeing improvement in all of my patients. How do you approach oral hygiene and broken bracket conversations and tips for navigating? Thank you.
Well, thank you so much. I hope you guys attend my lecture at the AAO in Chicago. It's going to be a very personal talk. It will be about my residency experience, which was a tough one for me. But one moment I remember, we had a patient with very bad oral hygiene. He was about 14 or 15-year-old kid. And at the end of the appointment, his parent just never showed up. And his parent was going through a lot, was having problems, probably substance abuse, who knows, all the problems. But I ended up, after waiting hours for someone to pick him up, just waiting with him, I just drove him home. And it was in a very tough neighborhood. And my point of that story is people have a lot going on, okay? And, and this boy had bad hygiene and was a good kid, but just, there was other things happening in his life that, that were requiring his energy. So it's hard because you want to go in there and say you need to do this, but you also have to be a place of support, so you can't be just another adult making life hard for them. So I always say, I go in, the old sports analogy, go in like a lion, out like a lamb. I go in hard and then I come back with a lot of compliments and love and motivation. And so a couple things that I do. One, be aware that there may be more happening. So it just may not just be a messy kid who doesn't care. This may be a child who's going through depression or struggling at school or getting bullied or all these other things that we all go through when we are in those awful middle school years. So I like to be very supportive about it. Two, I like to brush their teeth. I've said this many times. I brush their teeth. How many times do you have a patient go to the sink, brush their teeth, they come back, the teeth are still disgusting? So I actually grab a toothbrush, I pop it open, I brush their teeth. They're going to be bleeding everywhere. That's fine. I want them to feel how I want them to do it. And I know it's tough for them. It probably hurts a little bit, but I actually need them to feel how I'm brushing above the gums and below the gums. And I tell the parent, this is what I need from them. This is what I need them to do. A lot of times they need to experience the way to brush, and I will brush for them. But I also want to say this one point above all. no scarring the teeth. All right, your job above all is to make sure that patient is healthy when they leave, and you cannot leave them with 15 cavities. You can't. So if a patient cannot tolerate orthodontics, that's okay. They just get them done. Put them in an 18 night tie them in, wrap it up in 3 or 4 months, and be done. And it's not ideal. And you know what I will do in my office if I have to finish them with in-house aligners or Invisalign, and I will do that at no cost. And I know people's comment was, well, if they don't brush their teeth, they're not going to wear the aligners. That's fine, but then they'll take ownership of that. I can't be responsible for damage to their teeth. Yeah. So if a child is unable to maintain the hygiene, I take the braces off because you are responsible for their care, and you cannot scar someone. You have to leave people whole, right? And so to answer that question specifically, I motivate. I'm a little hard, but I come back with love. I brush their teeth. I want them to feel it. And if nothing works, we're done. It's okay. It's okay. I could always put them back on. I would never charge to put them back on. I could use my in-house aligners. I can use my Invisalign. I never add to the fee. It just is what it is. Here's what I'm going to tell you guys, and I hate talking about money, but let's just kind of, it comes up and it may come up again during this talk. You're going to make more money than you know what to do with. Whatever number you think, you're going to add 2 decimal points to it. It's beyond what you can imagine. It's beyond what probably we deserve. Okay. So don't make things about money in your office. In fact, the ones who make the most money are the ones who do not focus on it and who are generous. They cannot get out of the way of success. So there are going to be cases where you are just going to have to spend more than patient paid to do the right thing and be a good doctor and get this right. So there are cases where I will spend 2 or 3 times that someone has paid me, and that's okay. That's part of this overall arrangement of being a good ethical person. And don't worry about winning the financial game with every patient. There are going to be some losses, but as long as you got them in a good spot and you practice the right way, karma will work on your side and you'll gain from it. So it's a struggle we all have. And just because I'm posting beautiful cases does not mean I don't have cases where the hygiene is poor. I'm just not sharing those cases.
Well, that's great advice. And I mean, I respect you a lot for that. You're one of the most generous people I've ever met. Thank you for that answer. I'm going to keep moving on because they keep coming in, and I don't know if we're going to get to all of them. Next question: do you offer MARPE as a treatment option in your practice? Why or why not?
The MARPE, a skeleton supported expander. Yeah, correct. No, so I don't. We have an orthodontist, Azita Abbasi. I hope she's listening. A few miles up the street from me, who is who does it. And so if a patient comes in asking for it, I just refer to the orthodontist up the street for it. So I don't, just as a good rule of thumb, I don't say, oh, don't do that, or that's baloney, or I don't believe in that. If they want it, there's an orthodontist who seems to do this a lot up the street, and I will have no problem referring to that doctor for it. And she's a great orthodontist. I don't do it. Again, this is philosophy, so I don't mean to no disrespect. It's just a lot to do for a young child. So clearly they're effective. The results are amazing. Some of the complications are very scary. Dr. Yoon has that wonderful lecture she did at the AAO. These complications of facial fractures are unbelievably scary. And I think it's probably not a concern on an adolescent, but it certainly would be on an adult. But it's just, of all the things that I am going through my mind in a day, I don't know if I need to add something unnecessary. So I think it's a great addition to be used on a 20-year-old with a posterior crossbite. To use it on an adolescent, maybe not.
Got it. Thank you for that. Moving on. What are your favorite techniques to create and to level a deep curve of SPE, especially when there's excess overjet?
Yeah, heck yeah. Right. Well, a lot of times you get the deep curve of SPE because you have excess overjet, right? You're a little class 2.
Right.
Because of that depth of the bite, the lower incisors don't stop erupting until they hit the anterior palate. So my protocol in my office that I'm using is I'm building up to an upper 1925 stainless steel.
Okay.
And a lower 1925 reverse curve night tie. I actually like on brachycephalic deep bite patients with steep reverse curves of SPE to go into heavy reverse curve night ties. I want to extrude the posterior teeth, and then I combine it with running class 2 elastics off of that to help pull those molars up. I'll even go one step further. Once I get the overjet to approximate, I'll put upper, of course, anterior turbos, metal turbos, upper 2 to 2, because
Right.
I want to hold the bite open and get more posterior extrusion. For these brachycephalic deep bite patients, boy, it is hard to open the bite. Don't put posterior turbos. You're just going to deepen that bite. They'll intrude those
Right.
molars.
Yep.
There's nothing wrong using utility arches. I just love reverse curved speed night ties. So I really, years ago, I did a book review for the JCO by a wonderful orthodontist in Boston. And her whole book, she talked about using reverse curved speed night ties. So I asked Dr. Killick, who was an associate of mine, an expert doctor working in my practice. I said, what do you think about this technique? She's like, oh, yeah, I do them all the time. And then, boom, we just incorporated it and never looked back. So I like upper 19 steel, lower 19 reverse curved night tie, class 2 elastics. Once the overjet's close, upper anterior turbos.
Beautiful. I
A lot
love
of information.
that. No, this is great. I mean, it's like residency 101 in an hour.
That's the point. We can do these webinars every few months if people enjoy them.
You know, I'd be happy about that. Okay, coming into the next one. Do you allow parents to come back to the chairs with the patients? Simple question.
So our office is open. There are private rooms. If you're building a new practice, make sure you do have a private room. That private room should be at the opposite end of the waiting room, right? You do need a room for nervous children, loud families, right? There'll be situations going on where children will be nervous, crying. There'll also be just loud parents, and you just need to kind of create some separation. So you do need one walled off room. But our office is open, so parents can come back. We have a very busy practice. I don't know how there could be many practices busier. I actually need the waiting room to thin out. And I bought these really nice clear acrylic, so they're very high quality chairs for the waiting room, so they don't take up any visual space because they're clear. I do have benches, but really high quality seating. I actually want the parents to come back. I don't want, a packed waiting room. It's always full, but it can't give the appearance of past the threshold. And we're constantly fighting the perception of being too busy because we're very busy, but it has to be smooth. Your cadence in anything in life has to be smooth. And once you break your cadence, people start questioning. So I want parents to come back. Now, I will tell you, it was very enjoyable during COVID when parents stayed in the car, but that's different. If they're in the office, I need to thin out the waiting room, and I do encourage them to come back. I don't let them stand right on top of me. I'll make up some excuse. Like I'll say, you're standing in front of my light, you're blocking the light. I'll say whatever. I'll bump into them. I say box them out. I need them to give me some space. They're curious, but I definitely do not mind them coming back. Also, that sibling who comes back will be a future patient.
Very true. And I do the same as that. I love that protocol. Okay, moving on to the next question. I love this question. So, hi, Dr. Kravitz. I am I'm going to slaughter the name, Adith, based in Cambodia, and I love your work. How do you manage gingival embrasures or black triangles that sometimes occur at the end of treatment, especially in initially crowded cases? Do you tell the patients if there is a possibility of this happening?
Yeah. So a couple things. You have to always have candid conversations with people, right? So and that will. So you can't really touch a patient without their permission. What I mean by that is like a baby tooth that is just a shell of a tooth, a fragment of a baby tooth. It's just a piece of calcium. You want to go in there with a tweezer and just pull it out of the gums and think you're doing this great service. You cannot do that without making sure the parent knows that you're doing that. One, it adds value to what you're doing, but the occasional parent will get very upset because they're just worried about the feelings of their child, and their child may not want that. So, so IPR is a classic example. So I will say to the patient what I'm doing before I do it. Always explain what you do before you do it, add value to what you do, and then do it. So I'll tell the patient, listen, we're going to do this. It's infinitesimally small, but by doing so, we are actually going to be able to pull the teeth together. That excess enamel is causing this unsightly space, and it's actually better for the health of the gums. And I explain it. I go slowly. I use a red strip first. I don't go into with a heavy green strip. I don't make that scratching sound. And then I can go back in with a disc if I need to, but I am kind of easing them into the interproximal reduction. I am explaining it to them because the occasional patient will say, do not do this on me. But if you do IPR on a patient who does not want you to do it, you will be on the other end of Yelp. And so no matter how much they need it, because again, it's not what is, it's how they feel. It's not the reality, it's the perception. And if they don't want you touching their teeth, they will say you are shaving their teeth. You are, you know, so they don't see it as excess, they see it as unnecessary. So I explain to the patient, this is here, and I do the IPR. That's not a concern. The bigger question is what to do if you get unintended gum recession at the end of treatment. If that happens, and I think that my orthodontics created it, I will sometimes pay for the gum grafting. I would probably say I would most of the time pay for the cost of gum grafting. If you're a thin tissue phenotype and I did not warn you ahead of time that grafting was a potential, I should have, but if I did not, and I did not document it, I make sure money never changes your feeling about me. And that's a lesson to be learned. And I make sure for all thin tissue phenotypes, we talk about recession during the consult.
Thank you. I mean, I love all of that. Going to keep just busting through these because there's so many. Next question. What are the best ways to fix an occlusal cant in your view?
A cant is tricky. I have a unique, so there was a wonderful clinical pearl, I believe out of Syria, really cool, a great author who writes a lot on biomechanics. So I published a few months ago in the JCO, so please go back and check it out. That is an old technique taught that I learned by Dr. Baldwin, who lectured at Indiana, a very famous biomechanic. I believe he was best friends with Charlie Burstone, so I know Dr. Stewart's listening. So Dr. Baldwin's a famous name from the past. But he talked about using opposing waved arches to level the curve of spee. That's a classic technique. I have a unique approach. I will use posterior turbos on one side. So if I have a cant, I will add turbos on that cant side and lift it up, and then rubber bands to pull that down. So if I have a cant here, I have turbos here, propping the bite open. So now we're really open, and then I have rubber bands here pulling it down. So that's my technique. I don't know. I just kind of came up with it. It works great. So so there's a number of techniques. The clinical pearl that we posted, I was so eager to post it because it's a great orthodontist, and it's a traditional technique, and I think it's really important for everyone to see. But my techniques, opening the bite on the affected side, and then unilateral rubber bands on the opposite side.
You know what's funny? In all these years of doing this, that's the first time I've heard that. I love that.
Yeah, it works great. It works great. I just make
beautiful.
You know, that's the best stuff about our job. We just, you know, we just go.
Right.
Go.
Thank you for that. I mean, not only for the person you answered it for, but for me as well, and I'm sure many others. Okay, moving on to the next one. Kind of in the same vein of bite turbos, somebody posed the question, Dr. Kravitz, what is your percentage of patients that get bite turbos? I've been noticing that I may be placing the brackets higher in the lower posterior segments due to not being able to place the brackets lower on premolars. So do you place, what percentage of kids place those
A lot.
on?
You know, I'm a huge fan of turbos. I would say more than half, right? You know, so I use two types of turbos. I use metal turbos on the upper incisors. The metal is important. I know, listen, I wrote a whole article on resin turbos with Dr. Jurgensen, who was just one of my idols, and his son's one of my great friends, Brett. I hope they're doing well and hope they're listening. And that was a lot of fun to write an article with him. But I like metal turbos on the upper incisors. The metal will deprogram that muscles of mastication, those masseteric and temporalis muscles, and really cause the bite to relax and open. The resin turbos don't. Now, people use resin because it's easy to use, and you can really make sure the turbos are at the same like occlusal plane, right? Metal, you can actually intrude a tooth unevenly because they're not at the same height, so it's a little bit trickier. But I love metal turbos for that deep brachycephalic hypertonic bulldog bite. And then I use band lock on the lower sixes for your mesiocephalic patient. I used to use triad gel. I wish I could use triad gel. They don't make triad gel anymore. I will tell you, if you can't find Triagel. It's because I bought about 1,000 tubes of Triagel and I'm keeping it in my fridge. I'm not making this up, by the way. I have like 2 years supply in my fridge. But again, Banlock supporting Paul Gange. It's a comprimer. It actually has a fluoride release, so it's actually fluoridated, which is really nice. It's one of the unique properties of comprimers.
Mm-hmm.
So it's like a glass ionomer composite mixture. So lower sixes get Banlock, upper 2 to 2 get metal turbos, and a lot of my patients have some form of bite propping up. But to answer a lot of questions, a lot of people are using those 3M O-rings with the bumpers, the O-rings with the bumpers on the lower incisors to tie them in. And people seem to be doing that instead of turbos. But again, that is not deprogramming the bite. You still have a clenching bite. So I still like metal turbos.
I love it. Thank you. Moving on to the next. What is your protocol for incisor root resorption cases?
Yeah, you got to take the braces off. So you'll have patients who so I had a family of 2 who just came in, ectopic canines, blunted roots, right? You know, this is a genetic predisposition. This is a double whammy. This is very scary.
Right.
You do not bring these patients back every 12 weeks. You take x-rays every 4 weeks, and you talk to the parent all the time about what's going on. So they are predisposed to root resorption. They are genetically predisposed. And you know who's going to care about that? Nobody. You are in charge and you are liable. Nobody even understands this concept. All they're going to say is you caused it. This patient was going to get root resorption just from tongue thrusting, had nothing to do. But now you have to extrude a canine and you have intrusional forces on those incisors. These teeth are going to melt on you. If it could be a 4-tooth extraction case, I would love to take out upper canines, lower premolars any day of the week because it just makes my life so much easier.
Right.
So, on these cases, I try to get to clear aligners quickly. All right. So on these 2 boys who came in, they were twins. They had ectopic canines with blunted roots, like really, I mean, from the beginning, like they started treatment, they were blunted roots. I put them in braces for about 6 months, and then I went hybrid and then went right to Invisalign. You're going to see a whole issue coming out on the JCO on hybrid mechanics, which is a big wave in orthodontics. So I went from braces to Invisalign because the Invisalign was needed. The braces were needed to extrude the canine. The Invisalign was needed to prevent further root resorption on the incisors. And you can't worry about the money. Yeah, I won't make a lot of money in those cases, right? I had to buy 2 Invisalign lab cases. That's okay. That's okay. I can sleep well at night, and I'm proud of myself for catching it, and I'm proud of myself for and the parents really grateful, and that's being a good person and a good orthodontist, and the world will work in my favor. So
I love it.
You have to pay attention to it, and ultimately, like, just get off the teeth quickly, and use your aligners. This is where Invisalign is intended to be used.
Yep. I love it. That's my protocol exactly. And it works fantastically well. Thank you. So to everybody in attendance, if you've looked in the chat, Phil just informed me he's put a couple of links in there to items that Neal has been talking about. So if you want any more information, just make sure on the bottom right-hand side of your bar, look in the chat. There's links to a lot of the things that he's talking about right now. Okay, moving on to the next question. So I'm going to read this one because it's a little bit longer. Okay. So for African-American patients with flared upper and lower dentition and no space, it is difficult to get ideal overbite and overjet. These patients usually finish with increased overjet. In these situations, do you extract 4 premolars, or are you concerned about relapse due to limited tongue space and large arches? How much proclination is acceptable in this population?
So is this
long question?
You said at the beginning, is this a class 2 African-American patient with a class 2 malocclusion?
I think we're just going with a normal class 1. They didn't indicate that, but I would assume class 1, crowded, flared.
Okay. Yeah. Okay. So a couple things, right? So I want to go over some things. Again, a lot of this stuff I like to always, I hope with teaching, I always speak from the heart, and I hope it's okay. And I think the only way I can be is just be me. So I hope it's okay. And if I say things wrong, I never mean it to be inappropriate. I don't believe in like racial norms. I think there's a Hollywood norm, right? I believe that there's like a beauty norm. I don't think it matters whether you're Asian or African American. I think like there's a beautiful aesthetic, and I think whether you're Indian or African American or Asian, we can all look at a beautiful smile and say this is it. But I will say I am more cautious about extracting on patients who are a little heavier and have maybe a larger BMI or maybe a larger tongue. And definitely adults, because it's really hard to close that space and it's almost impossible to hold it once you close it. If I have to extract, I will take out those second premolars. And there's nothing wrong with just extracting in one arch in the beginning. And then if you have to extract in the lower arch, do it. Because I have a lot of cases where like I'll do 4 bicuspid extraction and the teeth are perfectly straight. The smile looks money, but I have like excess overjet. And I'm going, well, I just, we're not using J-hook headgears anymore. Our mechanics they're not better than they were, 20 years ago. They're probably worse. And I have excess overjet, and I'm thinking to myself, well, maybe I should have left the lower premolars in and maybe a little bit of posterior crowding. And I beat myself up over it. So there's nothing wrong taking out upper 4s if you have to, or upper 5s if you have to, and just seeing and tell the patient, you know what, like if you have to cover the cost of the second sedation, then you do it. Like that's okay. It's almost like a therapeutic lower arch extraction where you're just kind of seeing if you have to do it. So it's a tricky case. Bimax retrognathic patients are a nightmare, and I would treat it with upper bicuspid extractions and accept lower incisor proclination. I want to make sure I'm answering questions specifically, but that's how I treat. Because you're not doing 4 bicuspid in Lefort, 4 bicuspid in BSSO. So if you're not doing surgical advancement, just treat the upper, accept the lower proclination, put a fixed retainer. If they need surgery, they need surgery.
By the way, that was beautifully answered. Thank you.
Thank you.
I really love that. Moving on to next. So this individual asked, how do you correct a single molar crossbite when a patient is unwilling to wear cross elastics? Do you have any other techniques?
Yeah, so there's definitely a lot of articles, and maybe Phil can look this up, of mini screws used for molar intrusion. So you could put a simple, let's say it's the max. So a classic example would be like a maxillary second molar in a buccal crossbite that erupted like out of the tuberosity into a buccal crossbite. You could put a single posterior palatal mini screw, mini screw. Put the tube on the buccal, the elastic chain goes over the occlusal surface. Because the mini screw is from a higher angle, you're going to intrude and pull that tooth out. A crossbite elastic actually extrudes the molar more. A mini screw that's in the palatal arch or the palatal vault will actually intrude while you fix that scissor bite. So a mini screw works really well. A lower mini screw also works, but again, it's tricky because you're putting it in the buccal shelf, which is very slippery, and the tube has to be on the lingual of the lower second molar, which is right in the tongue area, so it's very hard to keep that bracket on. But a very easy technique is to put a mini screw between the upper 6 and 7 on the palate.
I love that.
Put a buccal tube, put an elastic chain over the occlusal table, and intrude it, and it pulls right out. That's a no-brainer.
I love that. I just added another one.
Taught to me by Dr. Budi Kuznotso. So Dr. Kuznotso taught me that technique.
That's fantastic. Actually, Phil just sent another link into the chat if y'all are looking for more information about that. One just dropped in the chat, so copy and paste that before we lose it. Thank you, Neal. So moving on to the next. This is coming from a resident. It says, do you have any tips on finding your preferred wire sequence and treatment protocol before graduating and entering the real world? Simply because there's just so much going on in residency.
Yeah, so I will tell you, I did not do O2. Well, I did a lot of Damon, like as a resident. We went to a Damon program. But I never extracted. I treated a lot of cases as a resident, hundreds of cases, believe it or not. But I only extracted in 2 cases as a resident, and I extract in about 25% of my cases now. So, you're going to practice probably differently than how you did. I do a lot of functional appliances now, but I think I may have put 1 in as a resident, and I put in 10 a day in practice. So so to answer that question, I think the beauty of the JCO is that we're going to talk about wire sequencing. I don't let people write case reports without a detailed explanation of their wire sequencing, and you can learn, and you can see what people are doing. And so just like the first question was that I actually stepped down, which is like not what I was taught to do. I was taught to just keep building up. But then all of a sudden you put a finishing bend on a 1925 steel and the patient's eyes pop out of their head. You don't want to do that anymore. Or you don't want to do that, or the bracket breaks off. So, and I also can actually detail better in a lighter wire. I'm just better at it. I'm actually more precise with it. So to answer that question, I would say is this, like, there's so many ways to finish. I think there's no right or wrong. I do think you have to pay attention to torque. I think the more you practice, the more you start to really respect the older orthodontist who put a greater value on torque control.
Yep, I agree.
And I think whatever you use for finishing and detailing, just remember there's no free lunches. If you don't get on your second molars, you're going to have problems in retention. A fixed retainer doesn't solve your problems. So what I mean by that is if you don't have good root parallelism, the old Wick-Alexander, lower incisor angulation, if those teeth aren't in a good spot, they will be the first teeth to relapse and break free from your bonded retainer. So, good retention's good retention. The old school is the best school. So the wire sequencing is whatever you feel comfortable with. Don't worry about saving money. Play with different techniques. See what you like. Use braided wire, use 2125s. Don't be afraid to finish in a night tie. All of them work. None of them work.
Yeah.
And I think as long as your goal is a great result, I think it's all fine. There's no hard rules in orthodontics.
That's beautiful advice. And I know this isn't Ask Mike Maru night, but I am going to add one thing to that. I feel that if you see somebody who you really respect their cases and love how they treat, it's a good place to start. And so those who are listening to this, I look at, Neal's cases, and your cases finish beautifully. If I were graduating right now, I would look and say, hey, if I need to start somewhere, do what Neal does and then work from there. Because having a baseline to start with is great. And you seem like the perfect mentor. Well, you are the perfect mentor.
So my wire sequence is pretty straightforward. It's 014 night tie, 18 night tie, 1725 night tie, 1925 or 2125 night tie. And I use that because I have a lot of slop in my brackets. And then I step, 1925 steel. So I have a lot of wires. And then I will start stepping down. So I kind of go up, and those last 4 months I start to go down. And I actually really sometimes just like to go into an 18 night tie at the end and just touch it up. I like to really, I feel like letting the teeth breathe helps me out a little bit. And I'll sometimes do an upper 18 night tie, an upper 18 in the lower arch, like a broad 18, and just kind of like get off the teeth in a way, if that makes any sense. And I think that sometimes that helps my alignment out.
Love it. So. Thank you for sharing that too. I think it's very helpful. I know we have about 11 minutes left in this, so I'm going to keep moving forward. For canine substitution cases or buildups for peg laterals, will you do the restorative work yourself?
Yeah, so depends if I like the dentist. So let's tell you, that's
that's funny.
That's funny. Me. This is Temple Beth Kravitz going on right here. So listen, I mean it. Like, so I tell the patient, I look them in the face and I say, this is temporary. You have to, you can't come in here. I don't say you can't come in here. I don't say anything like that, but I don't want them coming in every month. Bonded restorations will break. And even, Dr. Rosa, who is the expert at canine substitution, and his articles in the JCO for the residents, Rosa and Zackerson, his articles, if you Google Dr. Rosa and then obviously Dr. Zackerson, these names, you have to know who they are. They are the greatest on this field. And their articles, and they've actually wrote about 3 or 4 landmark articles on the subject in the JCO. I believe 1992, maybe 98, and then another one about 10 years later. But Dr. Rosa has gone away from composite bonding, which he called mesial composite bonding, and now just veneers the teeth. A lot of the European doctors, he said it will actually just work with a prosthodontist. So I will do the bonding, but here's what I want you to do to answer your question specifically. I want you to put that bracket at the gingiva. I want you to extrude that canine. I want you to do heavy enameloplasty so you don't need to bond the tooth. The more you practice, the more you don't want to bond that tooth, and the more you get aggressive with your enameloplasty and reshape that tooth. You can touch that canine and the tooth will be fine. And the better my cases look, it's because the more enameloplasty I had performed early on.
Beautiful. I love that. Okay. Gonna move forward. This is a follow-up to your previous wire sequencing discussion. If you're finishing in 18 NiTis, what is your preferred method for closing spaces if they open up? Are you chaining?
You have to do an under tie. Yeah. So what I call an under tie is I'll take a steel ligature. I use a light steel ligature, and I won't go do a tight steel ligature where I'm doing it tight. It's like figure 8 each tooth. So around each tooth, around each tooth, around each tooth, around each tooth. So it's firm, it's taut, but I'm not doing it a real tight twist. So it's really just a quick figure 8 under the wire, and then I go back into a night tie. Anytime I step down and I'm afraid of space reopening, any extraction case, I don't believe the cinch will hold. I need to do an under tie with the steel ligature. Thank you for clarifying that. Awesome question. That was a great question.
Great, thank you. Moving on to the next. How do you manage a class 2 bimax case? Molars in class 2, upper 4 extractions, but not enough overjet because of severe lower anterior proclination. How do you manage that? And that was a very specific question. Do you want me to read it again?
Yeah. So class 2 bimax with not enough overjet. So class 2 div 2. Yeah, I mean, I think. So here's what I would tell you. No matter what the molars are, let's say there's like lower anterior crowding, and the molars have migrated mesially, where the patient's class 2 skeletal but class 1 molar. I'm extracting upper 4s, lower 5s. I'm still extracting in a class 2 pattern. Now, if they're class 2 div 2, you never extract teeth. So here's a little rule of thumb. I rarely extract, if ever, a class 2 div 2, no matter how crowded they are. Class 2 div 1, I'm extracting. Now, I know the argument is like, if you align a class 2 div 2, you turn it into a class 2 div 1, and now you're extracting. But a class 2 div 2 is usually on a brachy patient, and a lot of times these patients can accommodate their teeth. Chad Foster gave a great lecture. I mean, that was mind-blowing lecture on non-extraction cases. And, and a lot of those cases, I probably would have extracted. And then you see his cases, and I think a lot of people are like, oh, man, it makes me second guess. And I think that was the whole purpose of that article, webinar. So to answer that question, what's the main problem, right? So what I do when I have a big problem in anything in life, do the main thing first. The main thing is that overjet. So start with upper bicuspid extractions. You could always go into lower 5s if IPR is insufficient. So I'm starting with upper 4 extraction, non-extraction in the lower arch. I'm accepting proclination in the absence of surgery. It just is what it is. Again, a lot of patients need surgery. Therefore, you're going to have a lot of compromises. But I also want to add this. Don't knock doing extractions and a functional appliance. A functional appliance is a wonderful distalizer, and there are many times where I've extracted and I've closed the space and then run a functional appliance. It's not ideal, but it does work.
Love it. Thank you. Two similar questions in this same vein. First one, where are we? How would you manage a 4 premolar extraction case in aligners, or do you even do that at all?
So what we do is we do hybrid. So a case comes in, I want extraction. So what happens, what I believe, but I'm just guessing, in most offices, a case comes in, an orthodontist hopefully is willing to do extractions, but the patient wants Invisalign, and they say, okay, well, we're not going to do extractions now on this case. That's what I think happens. If it's an extraction case in my office, what I do is this. I say, you got to give me 4 to 6 months in braces. So we start in braces for 4 to 6 months. We do extractions. I really try to close about 50% of the space.
Mm-hmm.
And then I switch them to Invisalign. So it's about 4 to 6 months of hybrid. I don't charge more for that. So I need to get some of the space closed. I can accentuate root tip the way I want to do it. So I can throw the mesial roots forward on the lower molars, and the premolar roots, or the canine root distal. I can accentuate the way I want. So I do 4 to 6 months of fixed appliances, and I switch them into Invisalign. So that's my favorite technique on extraction cases. You cannot extract second premolars on aligners unless you have incredible control of your mechanics. You will intrude those molars, you will tip those teeth, it will be a nightmare to recover, and you will ultimately have to put them back into braces. So so I will, if I take out second premolars, short phase of braces before Invisalign. That's the answer to the question.
Love it. That's a beautiful protocol. Moving on to the next, because we're slowly running out of time. We might need to do another one of these soon. Okay. Hi, Dr. Kravitz. Thank you for doing this webinar. After graduation, how can we start using the functional appliances that we did not have any experience with in our residency? How do you approach this implementation?
Yeah. So one of the things that I want to do is well, first thing, again, our journal is going to have that information. We're going to have a ton of information on functional appliances. One of the big things that I want to include in my time here is like very practical stuff. So we're including aligners, but I also want to include functional appliances. And I learned a lot of my technique from all the Herbst articles and the Forces articles from the JCO. So I really mean that. There is a lot of great material in the journal on functional appliances. What I want to write about is the Mara appliance, and I hope to write a Mara article at some point. To answer your question specifically, start easy, go slow. Don't start on a serious case. Start on an easy case. Maybe they're not full step class 2. Maybe they're 50% class 2. My first Mara insertion was a total disaster. I totally did not know what I was doing. And you just kind of go at your pace. And I want to say this, guys, call me. Like, I'm on Facebook. You can email me. I just opened up a Twitter account. So I'm going to try that out for a little bit. So just message me and just I'm here for you, and I'll pick up the phone. We can FaceTime and I'll walk you through it. So I don't have a lot of specific answers other than just go easy, go slow, and don't be afraid to try it, because I've never did a Mara in residency, and I do 10 Maras a day in private practice.
Yeah, I'm exactly the same. Mara is my class 2 corrector, and I didn't learn it in residency. It's beautiful. Thank you. Okay, coming to the next one. Somebody was referring back to that Bimax case we were talking about in extractions. What are your thoughts on a lower incisor extraction in that case, or in any case, really?
I love it. I think it's fine. Okay. I think though, I think so. Here's so I call it. I want to write about this case report. I've always called this the Kokich technique, which I thought was a class 2 malocclusion with severe lower crowding in adults, where he took out upper bis and a lower incisor. So like upper 5s, lower 1, or upper 5s, lower 2, like a 3-tooth extraction protocol. I don't know why I called it a Kokich technique. I thought I read an article about it, but I can't find the article. But I've always in my head, no one taught it. I attributed that technique to it. So I treat a lot of Indian American patients who are Bimax and retrognathic. And if I don't want to take out lower 5s because they're so retrognathic and the lower incisor is totally blocked out, I will always do upper bicuspid, lower incisor. It works out great. It's one of my favorite protocols. The occlusion will make sense. You'll finish class 2 molar, but the overjet's controlled. You may have to do a little bit of upper IPR, but it works out great. So I love upper bi, lower incisor on a class 2 Bimax with severe lower incisor crowding. That is a great comment that I'd love to end on. I'd like to make one point, guys, as we wrap up today. Mike, I told you this when we started. What an asset you are to the JCO. You are You have become an associate editor, but you really have become such a key figure in taking our journal digital. And these webinars are huge. I hope you've enjoyed it all. To the residents and the doctors who are listening, we need your support. We are the largest and the most popular clinical journal in orthodontics in the world, but we need your subscription. And I kindly ask that if you enjoy what I am doing with the JCO, if you enjoy how we are trying to make this a very relevant and useful journal where every article can be applied clinically right away, your subscription means a great deal. For the residents, you cannot beat the price. It is a half cost subscription, even for a year after residency. And for the orthodontist, it is the cost of a evening out or a staff lunch. This is a privately owned journal. We have an incredible editorial board. We brought on some wonderful new editors that I think you will love. Dr. Palomo just joined us. He is the world leader in sleep apnea. And your support will mean everything, not only to me, but to our entire JCO family. Please subscribe to the JCO. Thank you guys so much.